much appreciate your time in joining us tonight. Forgive me if I seem a little out of breath. I just came up from clinic, and I swear half the patients were dry eye patients. To get disclaimers out of the way, I have no financial interest in any brand names, medications, or devices that may be mentioned in this talk. Who has dry eyes? Everybody. Dry eye disease, dysfunctional tear syndrome, or the newer classification, disturbances in the lacrimal functional unit, is among the most frequent diagnoses in ophthalmology and may account for as much as 33% of patients in dry eye clinics seeking ophthalmologic intervention. It was long basically ignored, but it's now recognized as a critical and significant public health issue and has been linked to depression and suicide, among other problems. Who has dry eye disease? Patients most likely to have dry eyes include peri and postmenopausal women, pregnant women, 20% of men, patients who wear contact lenses, corneal refractive, cataract, and aesthetic surgery patients, patients with systemic diseases that will be listed later in this talk. In all, over 78.5 million Americans may be suffering from dry eye disease. 75% are over the age of 65. 7 to 10 million Americans have some type of dry eye symptoms and use artificial tears daily. The average age of a dry eye patient is 54. The ratio of women to men with dry eye is 2 to 1 in the over 50 age group. Why is dry eye disease so important? It's a multifactorial disease which results in destabilization of the tear film, resulting deterioration of visual quality and comfort. It can lead to an inability to perform daily activities, leading to an increased risk of psychosomatic disorders such as depression, stress, and anxiety. Daily problems for us today. Why is it so important? Other than the obvious. It is a multifactorial disease which results in destabilization of the tear film with resulting deterioration of visual quality and comfort. It can lead to inability to perform daily activities, leading to an increased risk of psychosomatic disorders such as depression, stress, and anxiety, all of which we have enough of already today. There's a greater risk of eye infection with dry eye disease. And in progressive, severe cases, it can lead to irreversible ocular surface disease and blindness. The impact of dry eye disease is significant. In patient assessment utility scores, scaled such that a scale of 1 was rated as perfect health and 0 was the equivalent to death, utility scores for dry eye disease range from 0.78 to 0.72. While angina was scored 0.71. It may have profound impact on surgical outcomes because of the inaccuracies in biometry and IOL calculations. It may also have a very unpleasant impact on satisfaction with cosmetic lid surgery and refractive cataract surgery. Do you hear this complaint frequently about a dry, scratchy feeling? We listen carefully enough. Apparently, if you are not hearing this or similar symptoms in about 30% of your patients, you are not listening. Symptoms of dry eye disease are symptoms and complaints that you hear every day. They include a stinging, burning, sandy or gritty feeling, or a foreign body sensation. You will hear that the patients have episodes of excess tears or frequent complaint of watery eyes. complain of pain or red eyes, complain of heavy eyelids, tired eyes, or eye fatigue. Some complain of an inability to cry when emotionally distressed. They also complain of discomfort or inability to wear contact lenses and a decreased tolerance for working on the computer, cell phone, watching TV, or reading. One of the main complaints that I hear every day is filmy or fluctuating vision. That is pretty pathognomonic for dry eyes, aqueous dry eyes. The risk factors for dry eyes are dry eye disease or dysfunctional tear syndrome is everything. If you look at this list, there are very few things that are not included in it. As it exemplifies, there are numerous factors that can influence dry eye. Non-modifiable risks include age, female sex, race, meibomian gland disease, autoimmune or connective tissue diseases, and diabetes. I get many referrals from the retina doctors for their diabetics that complain of dry eye disease, and it's a special problem in itself. The modifiable factors include androgen deficiency or hormone replacement therapy, medications, diet, extended tasks such as using the computer, driving, contact lens wear, and environmental, including pollution, low humidity, sick building syndrome, and surgery. The systemic diseases in dry eye disease are myriad. They may include connective tissue diseases like Ehlers-Danlos, Marfan syndrome, scleroderma, soft tissue sarcoma, trachoma. It is very important that you do the social history in patients coming in with dry eye disease. Alcoholism may lead to vitamin A deficiency or a poor diet, which is conducive to dry eye disease. Drug abuse. Cocaine may cause an anesthetic cornea. And I've had several patients come in, young patients, that had failed treatment elsewhere. When you question them about some of their illicit drug use, they may use cocaine and their cornea is anesthetic. They can't feel the dry eye disease, but the cornea has SPK everywhere. Now on to patient evaluation. A number of questionnaires have been developed to assess a patient's subjective experience of dry eye symptoms for a more objective and reproducible data that can be used to manage, treat, and monitor patients with dry eye disease. Currently, the most commonly used and quickest is the Ocular Surface Disease Index. It is self-administered and has 12 questions and a scale of 0 to 4 for severity and frequency of symptoms. This can be filled out by the patient in the waiting room and scanned into the chart. A number of medications can cause problems. You should add, for one of the first things you should take is a medication history. Medications that include drying effects include antihypertensives, antiandrogens, including those used for prostate cancer and treatment for menopause, antidepressants, anticholinergics, antihistamines, heart medications, Parkinson's disease medications, mini glaucoma eye drops as they contain preservatives which are drying, hormone replacements, and birth control pills. So the patient evaluation starts with a detailed medical and medication history. There are a number of diagnostic tests for dry eye disease and dysfunctional tear syndrome. ranging from a simple fluorescein strip for tear breakup time to a computerized map of the meibomian glands. You need to be familiar with at least two of these tests, one for aqueous deficiency and one for evaporative disease. I have to admit, there is a historical test that in the past everybody was told was very important and you had to do it for dry eye disease. That's a Schirmer's test. In my opinion, it actually is pretty worthless. And the only people that really ask for it anymore are the rheumatologists. So you should still know how to do it, but I would not necessarily include it in my armamentarium for treating or diagnosing your dry eye. There are a number of clinical signs for dry eyes. Injection, of course, is one of the main symptoms, and many patients come in complaining of red eyes, and even though they think it's a cosmetic defect, it is a symptom of a real medical problem. Foamy tears, which I don't know if you can, or saponification of the tears, you see looking at the chart or the slide, usually happens in the outer canthus and along the lid margin. It actually looks like little bubbles, and that's a very important sign that there is a dysfunction of the meibomian glands and a staph overgrowth. Tear film breakup is a very important test, the normal being 10 to 15 seconds. Everyone should know how to do this. You do not do it with the fluoresce that is used to check pressure. You must use balanced salt solution on a strip of fluorescein paper. I usually have patients pull their own lower lid down. It makes them feel a little bit more secure about somebody being that near their eyes. And then I rub the fluorescein strip along the inferior palpebral conge. I do it about 5 to 7 times to get enough fluorescein in there. Or if that's difficult, you can lay the strip on the lower conge and have the patient blink a few times. Normal is for it to take 10 to 15 seconds to break up. Abnormal is less than 10 seconds, and it's indicative of a lipid or mucin deficiency. The fluorescein stain pattern is very important. If you see the lower third of the cornea, it can indicate lid or meibomian disease, lid malposition, or the eyes being open while sleeping, or lower lid laxity. If you see the staining in the palpebral fissure, it can indicate exposure, and this often is associated with neurodiseases like Parkinson's. If you see diffuse epithelial breakdown, this is common in diabetics, and you will see it not only in the exposed areas, but even under the lid if you pick the lid up and look. The blink rate is important. If you watch a patient's blink rate, the normal blink rate should be about 22 times a minute. You'll see this decrease to about 7 times a minute in computer users, long distance drivers, people who are watching TV or movies. It may be even longer in Parkinson's or other neurological disease. There's a new dry eye description that's been updated or definition, presenting a 3-part classification system. Dry eye problems or disturbances of the lacrimal functional unit comprised of the lacrimal glands, ocular surface, and eyelids. Now, while the terms aqueous deficient and evaporative dry eyes have been removed from the definition of dry eye, they remain valid within the etiological classification. A majority of your patients will have evaporative disease. Approximately 80% of patients will have evaporative disease as opposed to aqueous disease. K-Sicca is now limited to use within Sjogren's syndrome. The old days that when tears were thought to be plain water and salt are gone. The normal healthy tears contain, in addition to water, a complex mixture of proteins, mucins, and electrolytes. The most abundant proteins, lysozyme and lactoferrin, have antimicrobial functions. Immunoglobulins such as IgA, IgG, and IgM also have protective functions. Cells are constantly sloughed off and lost from the most superficial layer of ocular epithelial. Growth factors are very small proteins that regulate the process for replacement of epithelial cells and are necessary for wound healing. Many growth factors are present in tears, including the epidermal growth factor, as shown here. Mucins are critical for the viscosity of the tear film. The soluble mucin is secreted by conjunctival globulate cells, whereas membrane-bound mucins originate from the epithelial cells they are bound to. This is important because it contributes to normal shear factor. Patients with chronic erosion syndrome may have a problem with the mucus layer of their tears. This is something you can see if you use a lissamine green staining a lot of times. The electrolyte concentration in healthy tears are maintained in the proper ranges to ensure correct osmolarity, which is important for many aspects of epithelial and nerve cell function. This is why it's important to use a good quality teardrops. Not all teardrops are the same. I'll get more into this later. A healthy tear film is essential for optimal vision and protection of the ocular surface tissue. The tear film and anterior surface of the cornea actually provide about 80% of refractive power for the focusing mechanism, which is very important when you're referring patients for advanced technology lenses. The tear film breakup can degrade visual acuity, a special contrast sensitivity, which is especially important in the multifocal and extended range of vision lenses as they decrease contrast sensitivity to a certain degree. Anyway, one important thing to look at is if you do a pentacam and the patient has a high spherical aberration, that person is not going to get good results from a multifocal or extended range of vision lens. And so that's one place where you have to be very careful with that. The tears provide lubrication and comfort. The lipid layer lubricates. The mucin layer decreases the shear force associated with the blink cycle and pain. The tear film protects the mucosal ocular surface against desiccating environments and also against infections. The antibacterial proteins include lysozyme, lactoferrin, and peroxidase. The corneal epithelium lacks vasculature when it's normal, so it depends on the tear film to provide electrolytes and growth factors. Antioxidants also help to remain a reducing environment. Although dry eye may sound simple, the problem is really quite complex. Contrast the graphic of healthy tears on the previous slides with tears in chronic dry eyes shown here. The concentration of many tear proteins, including those with antimicrobial functions, are reduced. Growth factor concentrations are reduced as well. Soluble mucin 5AC is greatly reduced in concentration because of the profound loss of goblet cells from the conjunctival epithelium. It's typical of chronic dry eye disease. This impacts the viscosity of the tear film. Proteases that are present in healthy tears in a latent inactive form are activated in dry eye syndrome. They can degrade the extracellular matrix and the tight junctions between adjacent cells of the corneal epithelium. Activated proteases are also responsible for cleavage of many cytokines into an activated pro-inflammatory form. The increase in electrolyte concentrations means that the osmolarity of the tear film is increased in chronic dry eye, hence the importance of the tear lab diagnostic test that many people have. Symptoms And signs of aqueous deficient dry eyes include injection or redness, gritty, scratchy, mild itchiness, a foreign body sensation. The symptoms are fairly constant. You have increased osmolarity. You have a tear meniscus less than 0.22 millimeters. This is very important. A lot of people don't look at the actual level of the tear meniscus, but I find it's very important to look at that because that is indicative of less than 0.22 millimeters is very indicative of an aqueous deficient dry eye, which can make you think more along the lines of a systemic disease. The lactoferrin testing is positive, and patients will complain of a filmy vision more than a fluctuating vision. And the filmy vision is fairly constant. In evaporative dry eye associated with meibomian gland disease, the tear breakup is less than 5 to 10 seconds when the fluorescein test is done. You have an unstable lipid layer, and in some people you'll see an almost instant breakup of the tear film. They have foamy, frothy tears, frequently more visible in the lateral canthus and along the tear margin. The tear meniscus height is frequently normal, greater than 0.22 millimeters, or even increased. The conjunctival staining is greater with lissamine than with fluorescein. And there may be morphological lid changes. There may be poliosis of the lashes, lid notches, either very, very prominent meibomian gland orifices or almost impossible to see gland orifices. There's also a frequent thickening of the lid margin. Now to move on to patient treatment. In mild aqueous deficient dry eye, you want to again review the medical and medication history, determine if there's an underlying disease state that needs to be more adequately controlled, and or if there are any medications that are drying that can be discontinued or decreased. You should actually review the dietary and environmental factors. How much water does the patient drink? The current thought among how much water people should drink is it should be half the number of ounces of water per day should equal half the patient's weight. So a 120-pound woman should drink about 60 ounces of water a day, which is almost impossible to do, but that's the recommended amount. How much caffeine do they drink? Caffeine is dehydrating. More than 2 cups of coffee a day may cause some dehydration. How much alcohol? When patients are drinking alcohol, they are not dehydrating their body. Do they sleep under a ceiling fan? This is very, very frequent, especially among menopausal women. They look at you like you're crazy when you ask them, do you have a ceiling fan in your bedroom? But frequently they do. Do they use a CPAP? Can any of these be modified? Sometimes just simply modifying the patient's daily habits can be all you need. You need to educate patients on what may or may not aggravate the symptoms. Driving in the car with the fan directed at your face is a very prominent problem with dry eyes. Reassure them that you understand they have a real problem and that you will not ignore the problem or minimize it. Counsel the patient on over-the-counter lubricants. And one very, very important thing is to give written instructions and stress compliance. So again, in the treatment of mild dry eye disease, you want to educate the patient and talk about environmental modifications. Eliminate offending topical or systemic medications if possible. Do aqueous enhancement in the form of tear substitutes. You may still want to do eyelid therapy to help increase the lipid tear layer, because this will help still keep the aqueous tears around and treat any contributing ocular factors that may decrease the aqueous layer as well as the lipid layer, such as blepharitis and meibomianitis. For my patients, I try to give them a written instruction sheet listing their medications, giving them names, frequency, which eye to use, how and for how long they're supposed to use them. For most patients, for how long, I'll put until the next visit, because otherwise they will say, oh, 2 weeks after they start, they feel so much better, and they're going to stop their medication. I can't stress this enough. On their follow-up exam, repeat the tear osmolarity test, repeat the indicated clinical test, and if improved, again, stress that the patient is to continue therapy. I usually find in clinic that it takes at least 3 visits for the patient to actually get the routine down correctly and to realize that they need to continue the treatment. And then you can tell them to return to their routine scheduled visits. If no improvement, then you still want to repeat the tear osmolarity, repeat the clinical test, increase the frequency of tears. Here it's important that you use a preservative-free tear. Preserved tears should not be used more than 4 to 6 times daily. And unpreserved tears can pretty much be used as frequently as you want, as frequently as every hour or every 2 hours. You want to add a lubricating and or anti-inflammatory ointment at bedtime, stress compliance, and perhaps prescribe prescription medications such as Restasis or Xiidra. Or there's also a third new prescription drop called Cequa. It's similar to Restasis in action, but it takes effect more rapidly. Stress that medications like Restasis, Xiidra, and Cequa do require time to work and should be used at least 6 months before stopping. Restasis takes at least 3 months to show much improvement. Xiidra works slightly more rapidly in as soon as 2 weeks sometimes. There's also now an anti-inflammatory drop marketed specifically for dry eye inflammation and quote unquote flare-ups. It's called Isuvas and it's lodiprednol 0.25%. It's for short-term use up to 2 weeks and used 4 times a day. So that now you can use the lubricating drop like Refresh PM or Retain PM and the steroid concurrently. In the treatment of moderate dry eye disease, again, you want to use anti-inflammatory agents. You may also want to add systemic omega-3 fatty acids. It's important what type you use, and on a later handout, I'll show you some brand names that I consider good. You may want to consider punctal plugs. Usually start out with temporary punctal plugs to see if there's any help. I also sometimes recommend spectacle side shields and moisture chambers in addition to the treatment for mild disease. As with everything else, patients who go to Amazon can find dozens of types of moisture chambers and pick the one they like. On the second follow-up, you should still repeat the test. Confirm compliance. Have the patient tell you the routine that they are using. Don't ask them, are you using your teardrops 4 times a day? Because they'll look down and say, yes. Ask them to tell you their complete routine. Then do your clinical exam, check the intraocular pressure if you put them on an anti-inflammatory, and then consider tapering or stopping the anti-inflammatory ointment and just continuing the lubrication ointment such as Refresh PM or Retain PM. I stress these 2 because there are other ointments or gels out there. I don't find that the gels are adequate for nighttime use. They pretty much are gone in the first hour or 2 of sleep. You need to reassure the patient. Consider the punctal plugs, both upper and lower, if they've not received improvement from just the lower ones. Again, use the moisture goggles. You might want to consider using autologous serum where you spin the patient's plasma down. You have to send the patients to certain doctors who do that Usually they're cornea doctors because you have to have special equipment for doing that. But I have found that people that I send for these drops do tend to have significant improvement. In previous times, it was recommended to use testosterone drops. It's very hard to get these, and I've not found that they really help that much. In a patient who has a testosterone deficiency, that should probably be turned over to their primary care doctor to have lab tests done and to treat it there. Now, in evaporative dry eye disease or meibomian gland dysfunction disease, there's been a new term coined, dry eye blepharitis syndrome or DEBS, D-E-B-S. In this, you want to review their dietary and environmental factors. Are they vegan? Do they have a low omega fatty acid intake? Is there an excessive use of alcohol? For these patients, I recommend artificial tears with a lipid formulation, such as Refresh Advanced Unpreserved, Systane Hydration Preservative-Free, Refresh Digital Preservative-Free. You want to tell them to use warm compresses, and by warm, I mean as warm as tolerable, for a minimum of 15 minutes. They can buy commercial masks, such as a Bruder's mask or Optase, or I think even Sharper Image has one that you can time your warm compresses, and they cost anywhere from $5 or $10 to $120. Again, these can be obtained on Amazon also. They may also make themselves a homemade mask at home. If you have a cotton sock, like a cotton athletic sock, you don't want to use a synthetic sock, it'll melt in the microwave. But you half fill your sock with rice, plain old dry, uncooked rice, tie it off and throw it in the microwave, usually for about 15 seconds. Microwaves differ, so they want to experiment and have the sock compress to be tolerably warm without burning the eyelids, and use that. It's cheap and easy and can be replaced as often as needed. I also recommend lid cleansers such as Ocusoft, Steri-Lid, Avenova, Hypoclear, one of those. I very, very, very seldom recommend baby shampoo unless there's absolutely nothing else that the patient can use. I find that the baby shampoo is not as irritating free as it's advertised. Also, the dilution factor is very hard to reproduce from time to time. I'm very high on omega fatty acid supplements, since North Americans have among the lowest omega-3 consumption in the world. I recommend cold processed, not alcohol or heat processed. So usually the ones from Rite Aid, CVS, some of the drugstores, Walmart, they are the cheaper ones, are not the ones you want to recommend. Usually I recommend patients get a certain brand names that I will give a list of on a later handout. I also recommend a Z-Pack once a month for 3 months on patients who have actual tenderness along their lower lid margins. The Z-Pack is relatively safe. You can also use doxycycline, but that has to be used for about 45 days consistently. I find the patients much more willing to take the Z-Pack because it's only for 5 days, once a month for 3 months. There is also very little incidence of any type of GI problem with the Z-Pack. So if the evaporative or meibomian gland tear dysfunction is improved, you want to tell them to continue their warm compresses, continue their lid hygiene, continue their artificial tears, their omega fatty acids, and go back to their routine exams. If there's no improvement, I repeat the treatment and follow them up in 2 to 3 months. If there's no improvement at that time, you may want to consider meibomian gland expression, or one of the first things you may want to do before the expression is to use something called a BlephX, which is basically an electronic loofah for the eyelids that helps get rid of the biofilm that forms in meibomianitis disease and will allow for expression of the oil from the oil glands. Then you may want to follow up with one of the warmth and compression instruments like Thermal One Touch, iLux, or LipiFlow. I can't stress how important it is to give your patient written instructions. As you see on the film here, I have a written instruction sheet made up that I just go and check off what I want the patients to do. It gives them the name of their disease at the top, which many of them want written down. Explains a little bit about what it is, and then gives them a list of things to do as homework. Again, it has warm compresses, lid scrubs, ointments. The lid scrubs gives the name of the lid scrubs that I'm recommending. I can cross out the ones that I don't want. It gives the name of some artificial tears that I consider good, although I have a different list for that now too. It tells them how to take their Z-Pak. It reiterates that they should take it once, repeat it in 30 days, and then again in 30 days, and not take all three one after the other. It gives them the name of some omega fatty acid supplements that I like. I tell them that you can get them at certain vitamin shops or online. It also gives it lists the prescription teardrops that they may use and gives them instructions. And then below, there's some additional things that we may want to consider at a follow-up time. Anybody who wants a copy of this can request it, and I can send it to them via attachment to an email. So for severe dry eye disease, again, you want to go over the instructions and question closely. At this point, you may want to consider sending them to their primary care doctor for thyroid testing, hormonal or endocrine dysfunction, and certain inflammatory conditions. You want to check for estrogen in women and testosterone in men. You may be surprised at the number of patients I have found with low testosterone that their primary care doctors had not even thought of looking for. You may want to do rheumatologic testing for rheumatoid arthritis, Sjogren's, lupus, etc. At some point, if there are other factors like a chronic cough or shortness of breath, you may want to ask their primary care doctor to consider a chest x-ray and ACE testing for sarcoid. The treatment for severe dry eye disease used to cover systemic cholinergic agents, which I don't think are used much anymore, but can be used in extreme circumstances. Systemic anti-inflammatories, mucolytic agents, autologous serum tears. You can use contact lenses or amniotic membranes for diffuse SPK. I find the amniotic membranes to be particularly useful in diabetics, and there's been several diabetics who responded to nothing until you use an amniotic membrane on their eyes for about 2 weeks. You may want to consider permanent punctal occlusion of either the inferior, superior, or both punctures. In extreme cases, you may need to send the patient to an oculoplastic surgeon for a tarsorrhaphy, or at least a partial tarsorrhaphy. And you may, for men and even women, you may want to consider testosterone supplements. But again, this should be handled by the primary care doctor. Choosing an artificial tear, you want to decide whether you want to use whether you need preserved or non-preserved, whether it's an aqueous deficiency or evaporative disease or mixed mechanism form of dry eye disease, and how severe it is. Studies say there are no statistically significant differences between the effectiveness of preserved versus non-preserved tears. But in my clinical experience, some patients who fail to get relief from artificial tears with preservatives will gain significant relief from a preservative-free drop. Not only do they not have to contend with the preservatives in the drop, but they can use the teardrop more frequently. For preserved tears, I would recommend not using more than 4 to 6 times a day. However, with the preservative-free drops, you can use them up to every hour or two. Artificial tears should not be the primary treatment for dry eye disease, but I'm a big proponent for artificial tears, and it's a very, very good tool for temporary relief of symptoms. Patients should be evaluated for underlying causes and treated accordingly rather than relying on just alleviating the symptoms. This slide contrasts the complexity of the mixture of proteins, mucins, and other factors found in normal healthy tears with artificial tears. Artificial tears contain electrolytes which are balanced to mimic the osmolarity and pH of normal tears, but they still lack the important biological properties provided by the proteins and mucins that are present in normal healthy tears. That's why it's important to use a good quality tear that will provide as many of these important properties as it can. This is another picture of my medication instruction sheet. There should be a slide of my artificial tears. Apparently there's not. Okay. So, review of artificial tears. Artificial tears account for a whopping $540 million in annual sales globally. Many of there are different ingredients to the artificial tears. A popular one is carboxymethylcellulose or hydroxypropylcellulose. The tears that contain this include Refresh, TheraTears, Tears Naturel, Bion Tears, Genteel, and Retain. Other tears contain polyethylene glycol and glycerin. Among them are Sustain, Blink, Soothe. Polyvinyl alcohol is found in Murine and Hypo tears. And the oil-based tears include Soothe XP, Sustain Balance, Sustain Complete, Refresh Advanced, Refresh Optive Mega 3, and Retain MGD. For aqueous deficient dry eye disease, I recommend Refresh Optive, TheraTears, Tears Naturel, Genteel, Retain, Sustain Ultra, Blink, and Soothe. For the lipid deficient, I find that Soothe XP is good, along with Sustain Balance, Sustain Complete, Refresh Advanced, Refresh Mega 3, Retain MGD. Good all-around tears for mixed mechanism. I like Refresh Digital, especially for people who use their computers, their cell phones, their devices, and watch TV in large amounts. Sustain Hydration Preservative Free is also another good tear to use. So treating dry eyes is not a simple thing. It's a long journey, and it may take you many, many trial and error efforts. Dry eyes have been around for ages. This was the treatment from the Babylonian Ophthalmology Journal of 1553 BC. If a man's eyes are affected with dryness, he shall rub an onion, drink it in beer, apply oil to his eyes. Then thou shalt disembowel a yellow frog, not any other color, but a yellow frog, and mix its gall and curd and apply it to his eyes. This is enough to make the patient cry, and maybe that's what helped. But remember, it's a long journey, and there may be many roadblocks along the way. You and the patient both have to realize you may reach many milestones, and you may never reach the place of perfection, but you hope you'll be able to reach the place of satisfaction. And last, keep calm and carry on. We're all in this together. Have a good evening. It's open for questions now. So the first question, what is floppy eye syndrome and how is it identified? What role does it play in dry eyes? Okay, that's a very good question, because floppy eye syndrome is a very, very common problem that is very, very frequently missed. It's identified by patients who complain a lot of times of their eyes being very, very dry when they first wake up in the morning. And it is indicated in the clinical exam by staining on the lower, usually the lower half of the cornea, usually more on one side or the other. And it's usually on the side that the patient sleeps on because that eye flips open and rubs against the pillow. The way it is diagnosed is you have the patient look straight ahead, flip their lid over a Q-tip, and then see how long it takes, and let go, and see how long it takes the lid to flop down to its normal position. If it just sits there for more than 2 or 3 seconds, then you can be fairly certain that the patient has floppy lid syndrome. It's most common in people who are overweight, who have sleep apnea. That's a associated disease. And it's very underdiagnosed, but very important. For the treatment, I recommend using something like Refresh PM or Retain PM or some other thick ointment at night, and using a sleep mask to keep the eyelid from being rubbed on the pillow. Thank you. That was a very good question. Any feedback on Systane iLux or tear care? Not familiar with tear care, but the iLux it seems like a very good adjuvant treatment to your warm compresses and your other meibomian gland disease. I have had patients use similar treatments, and so far out of the patients that I have sent for that treatment, they've all been very impressed by the improvement they have had done. Some patients need it as often as twice a year. Other patients can get by with it once yearly, but it does seem to be very conducive to improve symptoms. Let's see. Are scleral lenses a good option for moderate to severe dry eyes? I'm really not a good person to ask that. I don't do any scleral lenses. I think I have read that, yes, they can be used for patients who have very, very severe dry eyes, but I can't, with any great authority, address this question. But thank you. It was a good question. Can you distinguish between evaporative dry eye and aqueous deficient dry eye based on tear osmolarity? Usually the aqueous deficient dry eye will have an increased tear osmolarity, or one of the things that many people don't realize is that even if the numbers are normal, if there is a difference of greater than, I think it's 7 points in the osmolarity, that can indicate aqueous deficient dry eye. And yes, you can, usually evaporative dry eye, you may have a perfectly normal tear lab, but an abnormal tear breakup. Thank you.